Assalamu alaikum. This is a presentation for medical students by Dr. Mumtaz Ahmad Umar, and today's topic is otitis externa. So in this presentation we'll be discussing introduction, its classification, the predisposing factors, pathology, the description of different types along with clinical features and treatment one by one. So introduction is otitis externa is basically an inflammatory condition of the external auditory canal skin, and it is characterized by edema and erythema with associated pain, itching with or without discharge. It can be both infectious or non-infectious. However, the inflammation when present, it can extend to the outer ear involving the pinna and the tragus anteriorly and inside the whole external auditory canal till up the eardrum or tympanic membrane. This inflammatory response in otitis externa, it is believed to be caused by a disruption of the normal pH and the protective factors within the external auditory canal. So one such thing is constant irritation or itching or scratching with the cotton bud or any other thing. It is also known as swimmer's ear or the tropical ear, though not the bacterial one, which will come later and see. So it is classified into two main groups, infective and the reactive. The infective one is the three types of infections: bacterial, viral, fungal and viral. And the reactive one include these three, which will be discussed later. Uh, Predisposing factors for the development of otitis externa. So there are certain factors which leads to development. If there is the anatomical type, those people who have narrow external auditory meatus, which may be hereditary, because every year the external auditory canal in every patient is different. Then due to iatrogenic causes, exostosis, which are the bony outgrowth, or any trauma, it will all lead to narrow external auditory meatus, leading further to development of otitis externa. And obstruction of the normal meatus, while wax, most common, keratosis obturans, any foreign body, hearing aid, earphones, etc. Dermatological conditions like eczema, seborrheic dermatitis, psoriasis, then allergic conditions which may be atopy, non-atopic allergy, exposure to topical medications, prolonged use of medications, uh, any other environmental factor the person is allergic to can lead to problem in the ear and become more prone to development of otitis externa. Physiological factors, if those people living in humid environment or any immunocompromised state. Traumatic, this is the why I've bolded, because this is the most common reason. uh, Continuous scratching with the cotton bud, or those people who have habit of cleaning the ear with cotton bud, the skin maceration after bathing or irrigation, ear probing, laceration, radiotherapy in this ear candling, these can all lead to trauma with development of swelling, edema, and otitis externa. And microbiological active chronic otitis media and exposure to the microorganisms. Those people who have chronic suppurative otitis media, the discharge when it is coming out cause irritation in the external auditory canal and can lead to swelling and inflammation. So usually what happens when the moisture is trapped in the ear after bath, showering or swimming, it can lead to otitis externa, because it is also caused by any other disorder which can cause a break in the skin of the ear canal, such as very dry skin, eczematous skin, or vigorous scratching or cleaning of the ear canal with objects like pins, paper clips, cotton buds, or any other foreign objects. And in cases someone has middle ear infection, which I have already described, the pus drain into the ear canal through a hole, cause irritation, edema, and leading to otitis externa. So this is the repetition. So otitis externa can be Acute, if it lasts, then this is basically for bacterial one. So acute when it lasts less than 6 weeks, and it may become chronic if it is more than 3 months. It can be localized or it can be diffuse. So the basic pathology is otitis externa is divided into three stages. The stage one is the starting stage, which is pre-inflammatory, and when this stage continues, it will lead to stage two, in which there is acute inflammatory reaction, which may be mild, moderate, or severe depending upon the severity of the disease. And stage three is the chronic inflammatory stage. So this stage three is in the chronic diffuse otitis externa. The localized otitis externa is usually acute. In acute otitis externa, we usually, as I already mentioned, any condition which lasts less than 6 weeks, it will be labeled under acute otitis externa, and there will be bacterial infection, often resolves with treatment but persist uh, less than 6 weeks. So stage one, the protective, what happened? The protective lipid acid balance of the external aortic canal skin, the normal pH in this area is 4 to 5, which is an acidic medium. It is lost, and the stratum corneum, which is the superficial layer of the epidermis, it becomes edematous, blocking of the sebaceous and apocrine glands, which is in the dermis, and producing oral fullness and itchiness. So basically what happens, skin. So we must know that skin, it is divided into epidermis, dermis and hypodermis. The epidermis, it is further divided into five layers. The superficial is the stratum corneum, then come the lucidum, then granulosum, then spinosum, and the lower one is the basal. And then come the dermis, which in the next slide I will tell. So what happened? It starts with the stratum corneum, the protective lipid acid balance, it disrupt, and the stratum corneum becomes edematous, and it then, when it becomes edematous, it blocks away the sebaceous and the apocrine glands. So this is epidermis. Now this up till here, and this the dermis. These apocrine glands and the hair follicles and sebaceous glands, they are present in the dermis. So when the superficial part is blocked due to edema, so these glands become blocked and will lead to the further development of the disease or progression of the disease. In stage 2, with further edema and continuous scratching, there is disruption of the epithelial layer and invasion of the organisms. So when there is maceration or breach in the skin, there will be invasion of the organisms, leading to pus formation and increasing edema. So side by side, both things are continuing. Edema will be there and pus will be leaking out, and this will cause obliteration of the lumen of the external aortic canal with or without cervical lymphadenopathy. So further stage 2 is further classified into mild, moderate and severe. Mild when there is little or no obliteration of the external aortic canal. In moderate one there is subtotal obliteration, while in severe intensity of this stage there will be complete obliteration, and the symptoms will be increasing in this stage. For stage 3, it is, as I already mentioned, is chronic otitis externa. So meaning that the condition has persisted for more than 3 months, and now it is characterized by fibrous tissue, hyperkeratosis and persistent inflammation. It is characterized by thickening of the external canal skin leading to atresia even. The basic difference mostly is after stage 2 there will be severe pain, but in chronic condition the pain will decrease and it will not be of that much intensity that it bothers the patient. That's why many patients, when they feel there is no pain, they think that their condition has settled, whereas the condition is worsening in terms of blockage of the external aortic canal. So now coming to localized otitis externa. So it is also known as fruncle or boil, and its main definition is the staphylococcal infection of the hair follicle. So in localized otitis externum, the main or infective organism is Staphylococcus aureus. Now it only affects the outer one third part of the external ear, which is the hair bearing area. This outer part is the cartilaginous part. There may be single or multiple fruncles which may be present. Whenever there is bacterial invasion of the single hair follicle, it results in a circumscribed deep skin infection. Now, when this infection it progresses, a pustule is formed, which is filled up with the pus and lead to the formation of local abscess with considerable associated cellulitis and edema. Bacteria initially attach to the cells of the stratum corneum, which is the superficial layer, and then proliferate around the ostium of the hair follicle. So it's starting from the top layer, the stratum corneum, and going deep down into the epidermis, into the dermis, where the uh, hair follicle ostium lies. So if we look at this picture, there is a small swelling or boil is formed. This now progresses. Here there is mild blockage of the external canal. This when it progresses, the swelling or edema increases and the blockage is almost 40 to 50%. This is the outer view, the canal skin, it is macerated, mild pus, it is dried out here, and the skin is, the external canal opening is very narrowed. In this picture, you see there are now multiple fruncles are there. Here it is one, this is two, and here it is three. So the external aortic canal skin is becoming very much narrowed. And if we look at this picture, there is pus, the abscess is formed and pus is oozing out, and almost 80% of external aortic canal is blocked. So in diffuse otitis externa, if this localized otitis externa it is not treated promptly, it may progress to involve whole of the external aortic canal skin. Then it is known as diffuse otitis externa, as there is diffuse inflammation of the meatal skin. It may spread to involve the pinna and the epidermal layer, the outer layer of the tympanic membrane. So outward, inward, the infection can spread. But who are affected more? Those people who are living in the hot and humid climate, the swimmers, those people who have excessive sweating, because sweat it changes the pH of the meatal skin to alkaline, favoring bacterial infection. Then those people who are habitual scratchers, they have the habit of scratching the ear or cleaning the ear with cotton but too much, or with cotton bud, or with pins or any other foreign object, it will lead to trauma of the meatal skin, followed by bacterial invasion, inflammation, edema, infection, and leading to diffuse otitis externa. For etiology, any condition or situation that disturbs the lipid acid balance of the ear will predispose an individual to otitis externa. This I have already informed you. So what happens usually whenever there is water and moisture, it is thought to cause a change from predominantly gram-positive skin flora to a gram-negative one. As I mentioned that in acute localized otitis externa, it is a staphylococcal infection which is gram-positive. But due to this moisture, there will be shift from gram-positive to gram-negative. So in acute, diffuse, and chronic, the Pseudomonas is the main. These are the gram-negative. It is the main infective organism from 50 to 65%. So as the ear becomes inflamed, the healthy cerumen which has its bactericidal properties. It is rapidly removed from the ear and it is no longer produced because of the inflammation. So this bacterial invasion will increase. So apart from Pseudomonas, other gram-negative organisms are also around 20 to 30, 25 to 35%, and Staph aureus also can affect in 15 to 30%, and Streptococcus in 9 to 15%. So if we look, because of the pus, the skin become macerated, dry, scabs, narrowing in the external canal. And if we look at this picture, the whole of the external canal, it's become very narrowed, almost 95% this area it is blocked. So for this condition, when we come to treatment, I'll explain what is the best option. Again, if we look at this uh, picture, there is the whole of the external aortic canal skin, it is inflamed and edematous, and same here, but here it is less, this is all congested, uh, and here the condition is little resolving. Now the clinical features, the most important clinical condition is the earache, and it is a very painful condition. Though severity, it do depends upon the stage, at which stage the patient present to us, but earache is the most common symptom with which the patient present. And this earache, how it is differentiated from the earache of acute otitis media, because in otitis externa, while moving the pinna, chewing, the pain will be there, but in acute otitis media, pain will not be elicited on moving the pinna. So earache, then ear discharge may or may not be present. So not every otitis externa have ear discharge. This is also important. Okay. Yes, many times ear discharge will be there, but it may not be necessary, or the patient may present without discharge. But patients do have feeling of fullness or blockage inside the ear. There will be, because of this blockage or edema and swelling in the external canal, hearing will be affected and it will be conductive hearing loss. Examination showed swelling and edema in and around the external canal. On pressing the tragus and pulling the pinna, there will be tenderness and pain. Movements of pinna are painful. Jaw movements, they are also painful. Patient may have preauricular lymph nodes, which may enlarge and are tender. So, dividing them into the phases, in acute phase, patient along with all those symptoms will be having hot burning sensation in the ear, and as already mentioned, pain, it will be aggravated by the movements of jaw, because just in front of the tragus is the temporomandibular joint, and the impression or bulge of temporomandibular joint is in the ear. So with inflammation in the anterior wall, this joint, there will be spasm of the joint, and pain can extend up till above, to the temporalis muscle, into the temple region, and below to the upper neck. So the whole side, one side of the face, the patient may be feeling pain. Again, depending at which stage the patient is there. Ear discharge, it will be thin, serous, and later on becomes thick and purulent. Uh, Patients may be presenting with itching, because whenever there is discharge, it stays inside, it will cause irritation and itch. Uh, Tuning fork test shows conductive hearing loss. Regional lymph nodes, when enlarged in acute infection, they will be tender, and there will be cellulitis and swelling of the surrounding area in the pinna, tragus, preauricular region, up till the parotid can also be swelled up because of the connection with fissures of Santorini. So all this area, it can be involved. In chronic phase, now pain is shifted more towards irritation and itching. So patient will be presenting with irritation and strong desire to itch. They may be, because of the swelling, will have oral fullness, blockage and hearing loss. Discharge may or may not be present, but crust, dry crust will be there. Meatus skin may show scaling or fissuring and stenosis, as I mentioned. And the stenosis of chronic otitis externa is little difficult to treat than in acute otitis externa. So diffuse, as I already mentioned, all the meatal external canal skin, it will be involved. There will be discharge, mucopurulent discharge, and this soreness of the external canal skin with swelling and edema is this. This is a tympanic membrane which is normal in this case and intact. In this, TM is not visible. So management options, the principles of treatment of otitis externa, the first and the most important step is the oral toilet. Okay, but again, while proceeding to oral toilet, if the patient has severe pain, then usually we will not do suction and cleaning in the patient or clear the secretion in the patient. We prescribe the medications and ask the patient to return after 2 to 3 days till his or her condition settles, so that we can do cleaning of the ear. Most of the times the patients, what happened, they have wax in the ear which causes them to scratch, so they do scratching with the cotton bud or any other object which causes trauma in the external auditory canal, leading to inflammation and swelling and development of otitis externa. So in such patients, the treatment will be two stage. In first stage, the infection has to be settled, and in the second stage, the wax has to be removed. So, thorough and regular oral toilet, ear toilet, oral toilet, same thing, and it means two, three things. We will discuss that later. Is the most effective single treatment for otitis externa. But as I mentioned, again depends upon condition. Every patient is different. So, but this is the first step of treatment if possible. Then topical medication, topical antibiotic drops, plain antibiotic or with combination of steroid that can be prescribed. Then analgesic depending upon the pain. If the pain is severe, then simple brufen or paracetamol, it will not resolve the pain or their condition. So strong analgesic has to be prescribed. Systemic antibiotics, again, if the swelling has started, then what I have observed from my clinical practice, we have to prescribe oral antibiotics as well, because at that time only topical medication will not resolve the condition in 80 to 90%. Yes, 10-20% may get better, but most of the patients which I have seen, the condition will worse if we only prescribe topical medication with the once the swelling has developed. Okay, the picture which I told you to observe in acute diffuse otitis externa, when the narrowing is too much severe, in such patients, if we only pour the drops, they will not go inside. So in such patients, we have to put the ear wick. So patients with marked edema of the ear canal require placement of an ear wick. Prevention, side by side, the prevention of the etiological factors that will lead to exacerbation, development or recurrence of otitis externa, they has to be managed as well. So these are the management option, not details. So in acute phase, oral toilet, which can be done by dry mopping, a doctor or a trained physician, what he can do, even cotton bud or apply cotton on a stick and then do dry mopping under vision. Suction clearance, it is the best option because it is less traumatic. Then under sterile conditions, irrigation of the ear with sterile warm normal saline can also be done. So this syringe, it's not syringing. Usually we don't do syringing now, but it's basically washing with sterile warm normal saline. So at the top, the most important or most commonly done in oral toilet is suction and cleaning. Then medicated wicks. So a gauze wick, we made a gauze wick and then insert, dip it in 10% ecthamol glycerin. This is this is an antiseptic with hygroscopic action, and it relieves the edema quickly. Or any antibiotic, steroid drops, preparation, cream, we dip the wick and then place it in the ear. Wick, there are two ways to do it. You can call the patient daily and change the wick daily for 2-3 days, unless the edema is settled and narrowing is gone of the external canal, or because the compliance is not too common in the patient, sometimes it's not feasible for the patient to come again and again. So what I practice, I put the pack in the ear and ask the patient to put the drops on this dressing for 3 days, and then either come back or remove the dressing. And in 90% to 95%, the results are very good. Oral antibiotics, you can start with penicillin. Most commonly prescribed drug is the augmentin, which can be given 1 gram twice a day for 5 to 7 days, or the quinolones, fluoroquinolones, ciprofloxacin or moxifloxacin, you can prescribe. Analgesics, flurbibuprofene, naproxen, diclofenac, all depends upon the condition of the pain. You can prescribe. And anti-inflammatory, the Denzen DS, which is seropeptidase enzymes, 20 mg twice a day for 5 to 10 days, has to be prescribed. Okay, so there are two ways of inserting the wig. I mean, there are two types of wigs. One, the regular wig, which is made from a small strip, is made from the gauze piece. Apply the steroid and antibiotic cream or drops or the thermoglycerin and place inside. Or this is the pop wick or the Mirocell wick. This wick direct inserted, hold with the crocodile, insert it in the ear, and then put the antibiotic steroid drops on it. For chronic phase, the main again treatment option is the oral toilet cleaning. Reduction of the meatal swelling uh, by placement of ecthamoglycerin wicks, antibiotic steroid cream wicks, or antibiotic steroid drops wicks, or application of cream or drops for long time, 2 weeks, 3 weeks. Alleviation of itching with prescription of anti-allergics. Then side by side, keep ear dry and look for any contributory factors which lead to this chronic phase and avoid or prevent them. One is constant putting of water inside the ear like swimming. This, as I already mentioned, is the swimmer's ear or the tropical ear. So one need to do that. And scratching the ear. So we have to look for that and prevent that. Recurrent cases. For recurrent cases, we have to exclude diabetes or any other immunocompromised state. See if the person is habitual scratcher, then he has to avoid scratching the ear. And attention must be paid to the patient's nasal vestibule, because that is also a hair-bearing area, and staph aureus may be present in that area. And if a person pluck hair or put finger in the nose and then scratch the ear, so there may be transfer of the organism from nose to the ear and will cause recurrence of the boils or otitis externa. So next is the malignant otitis externa. This malignant otitis externa, I have made the full presentation on it. So just a small review. It is an invasive bacterial infection of the soft tissue of external aortic canal and the surrounding structures, which can extend to skull base, and it is fatal. It is caused by Pseudomonas aeruginosa and mainly seen in elderly diabetics or those patients with immunocompromised state. So these are on finding there will be swelling or granulation in the external aortic canal. So early manifestation resembles simple diffuse otitis externa, but the pain will be too much severe and there will be development of granulations in the external aortic canal, and patient may develop facial paralysis. Infection may spread to the base of skull, jugular foramen, causing multiple cranial nerve palsies, to the temporomandibular joint, TM joint, and posteriorly to the mastoid or even to the middle ear and petrous apex. Diagnosis clinically with the symptoms otalgia in elderly diabetic with granulations plus minus facial palsy. CT scan show bone destruction. Technetium 99 scan is done to which reveals the bone infection is used for early diagnosis, and gallium 67 is used to monitor the disease. Treatment again oral toilet, long term systemic antibiotics with quinolones is the drug of choice, ciprofloxacin. But if CS shows resistance or any other, according to culture and sensitivity, you can prescribe that medication. Third generation cephalosporin can also be used. Topical drops should be added, and strong analgesic anti-inflammatory has to be done. Side by side, control of diabetes is also an important factor. Surgery is only considered when non-surgical methods, they treatment, they are proven to be ineffective.